Hi, everyone. Welcome to our first special seminar of the year. This talk is part of a special seminar series, which is entitled Towards Diversity, Equity, and Inclusion in Informatics, Healthcare, and Society. And we're very happy to welcome Dr. Megan Thress as our first speaker. She's an assistant professor in the School of Communication and Information at Rutgers University, New Brunswick. She's also visiting faculty at Yale School of Public Health, and her program of research centers around leveraging communication and information to reduce disparities in linkage and retention in HIV/HPV prevention and care among sexual and gender minorities of color. So with that, I'll hand it over to Dr. Thress. Thanks so much for being with us.
Thank you so much for having me. I'm going to go ahead and share my screen. Okie dokie. So thank you so much for having me, and thank you for the wonderful introduction. I am delighted to join you all, and I'm so happy to be part of this special seminar series. The work I'll be presenting today builds on ongoing calls in the field to leverage informatics to reduce health disparities and help improve the health outcomes of traditionally marginalized populations. So I'll be discussing formative research that I conducted that will be used to develop an HIV informatics intervention. And this was a community-based research study I conducted to explore how the social ecological and social technical environments of young Black men who have sex with men in the South shape how they access and interact with HIV-related information and their engagement in HIV prevention and care. So I'll begin by discussing the background briefly, as well as the purpose of the study. I'll share the research questions and the theoretical framework which guided the study, as well as the methods and findings of this research. And I will conclude with the design implications of this work and why health justice should continue to be a societal goal that the field of health informatics aims to achieve, and especially why it's so critical for ending the HIV/AIDS epidemic in the United States. So young Black men who have sex with men experience a disproportionate burden of HIV infection in the United States. The Center for Disease Control and Prevention predicts that if current HIV diagnosis rates persist, about 1 in 2 Black MSM in the US will be diagnosed with HIV during their lifetime. That's 50%. And in the Southern United States, Black MSM account for 6 out of every 10 new diagnoses among Black Americans. So, as alarming as these statistics are, I don't believe they have to be a foregone conclusion, but more so a call to action. So this June will mark 40 years since the first cases of what would later become known as acquired immunodeficiency syndrome, AIDS, were reported in the United States. And over these past 4 decades, there have been significant advancements in biomedical HIV prevention and treatment that present an exciting opportunity to combat the transmission and acquisition of HIV, such as treatment as prevention, and one that became really groundbreaking recently, which is known as undetectable equals untransmittable, or U equals U, which means people who are living with HIV who are taking their HIV medicines daily as prescribed and achieve and maintain an undetectable viral load have effectively no risk of sexually transmitting the virus to an HIV negative partner. So this is really groundbreaking. But despite some of these significant advancements, disparities in HIV prevention and treatment outcomes among young Black men who have sex with men, they continue to persist, such as late screening for HIV. They're more likely to be infected yet unaware. There's low uptake of HIV prevention methods such as pre-exposure prophylaxis. And so we need a better understanding of some of the drivers of HIV infection. And in order to reduce these disparities and to reverse HIV epidemic trends, that requires an interdisciplinary approach or approaches to increasing the utilization of these advancements by addressing barriers to prevention and care engagement. And so over the years, as people have saw some of these major biomedical advancements come out, they wanted to get a better understanding of why some of these disparities persist. So since they've wondered this, one of the first things that people typically do when they see these kind of disparities is that they initially focus on sexual and drug-related risk behaviors such as condomless intercourse, high alcohol consumption, or having multiple sexual partners. But engagement in these behaviors actually do not explain the disparities. And in several studies, young Black MSM report lower or similar rates of sexual and drug-related risk behaviors in comparison to MSM of other ethnicities. So to gain a better understanding of low engagement in HIV prevention and care, I decided to examine factors in their social ecological environment that might be impacting engagement. And then something that was especially interesting to me, given this age of misinformation and disinformation that is especially rampant on social media sites, I thought maybe examining the social technical environments of young Black MSM and examining their information behaviors, such as where they how they access and interact with HIV related information, would be especially important. And so, like I mentioned, health information is critical, especially, HIV/AIDS information is critical, critical resource for people, not only living with HIV, but people who may be at high risk for HIV infection. Managing HIV infection, as well as assessing risks for acquiring or transmitting HIV, as well as, deciding to adopt HIV protective and risk reduction behaviors to minimize risk for HIV requires, the acquisition and the successful application of this information. And so, of course, we know, while possessing HIV/AIDS information does not, automatically lead to health behavior change, individuals must be informed before they are, motivated and equipped with the skills to perform HIV protective and risk reduction behaviors, right? And quite often, the role of information in health behavior is a bit understated. It's usually relegated to things like health literacy or knowledge tests. But I think instead of explicitly focusing on the metrics of what people know, it may be helpful to enrich our understanding of how and why people know what they know, right? How and why and where they acquire and use information from various sources. With that in mind, these are some of the research questions that my formative research sought to understand, because we don't really know much or anything at all about how and why young Black MSM acquire and use HIV/AIDS information. And, given the rapid expansion of, technologies and online platforms such as mobile devices and, geospatial dating applications and social networking sites, these present channels for acquiring HIV/AIDS information. And these innovations have the potential to be mediums through which this critical information is disseminated and communicated. And also, as I mentioned before, examining, folks' social ecological environment. So understanding what are some of the factors in their environment that might motivate or deter the utilization of HIV prevention and care strategies. And in this study, I explicitly focused on pre-exposure prophylaxis use and HIV testing. So the theoretical framework guiding the study is guided by theoretical models and conceptual frameworks of information behavior, which originated in the field of information and library science. And so if you're unfamiliar with what information behavior is, it refers to the study of how people generate, seek, receive, give, manage, and use information in different contexts. And the information behaviors explored in this study were information seeking, which refers to intentionally sought information. The other information behavior was information encountering, or sometimes it's referred to incidental information acquisition, which refers to acquiring information that maybe you didn't intentionally seek out, or you passively received. And Sandy Erdeles calls this a memorable experience of unexpected discovery. And then finally, information use. And so there's two types of information use that were explored in this study. One being applying information, which refers to the instrumental application of information, and then the effects of information, which is the changes brought about by this information. So this study, I used a community-based participatory research approach, which included involving, community members, not just as research participants, but also as community partners. And so I had a youth advisory board that was comprised of 5 individuals, young Black men who have sex with men, who were living in the state of North Carolina, and they helped pretest the survey instrument. They helped refine the interview guide, and they were just really instrumental with this study at every step of the research process. So they provided clarity, they provided feedback on the clarity and wording of questions. They helped add additional questions that weren't in the that weren't in the study instruments, and they were also really helpful for identifying and recruiting participants for this study, as well as the dissemination of findings. And so I have a few, some of my community partners are here on the slide, such as the Triad Health Project and the Western North Carolina AIDS Project, were really helpful in this research. One piece of the methods included a survey that was implemented during the first phase of the study. I had 83 participants, most of whom who identified as gay or bisexual, and they were between the ages of 18 to 34 who were living in the state of North Carolina. The survey instrument had questions that were adapted from the Health Information National Trend Survey, the National HIV Behavioral Surveillance Questionnaire, and a study by Meadowbrook and colleagues that focused on HIV information behavior. The survey instrument was about 72 questions, and some of the questions that were explored were, sources of acquired information, the types of HIV-related information acquired, how folks use the information, as well as their trust of information sources, as well as preferences. Also, I apologize for the sirens. And then I also asked folks about, technology use, past mHealth, eHealth use, as well as their engagement in HIV prevention and care. And so descriptive analysis was conducted of the survey data. Following analysis of the survey data, in the second half of the study, a subset of 22 survey respondents participated in semi-structured interviews to, help elaborate findings from the survey and to capture things that may not have, been reflected in the survey responses. And as I mentioned earlier, given that this was a community-based study, the Youth Advisory Board actually provided feedback on the interview guide and suggested the addition of 2 questions, which were, what are your existing information needs, and how are your existing information needs not being met by healthcare providers? And you'll see here the interview respondents were sampled purposely. So I have 9 participants who were living with HIV, 7 participants who were HIV negative but using pre-exposure prophylaxis as a biomedical HIV prevention strategy, and 6 participants who were not living with HIV, who were not taking pre-exposure prophylaxis. And as I mentioned, the interviews helped to elaborate on some of the findings, from the survey, and to illuminate things that maybe we didn't add in the survey. And I conducted thematic analysis of the interview transcripts. So I'm going to present some of the findings. It may be of no surprise that information seeking was, primarily done online using the internet, and most folks, they, sought HIV/AIDS information, and it was mediated by, the default search engines on their mobile phones. And the top sources of intentionally sought online HIV/AIDS information was consumer health information sites, government health information sites, social media sites, and community organization sites. We found that the most preferred sources of HIV/AIDS information were a doctor or a healthcare provider, followed by the internet. And the most trusted sources of HIV/AIDS information were a doctor or a healthcare provider, the internet, and libraries. And so information encountering, which I mentioned before, is the incidental acquisition of HIV information, was very high via advertisements on social media sites and dating applications such as Jack'd and Facebook. Several people in the study, or most participants, discussed also encountering information due to postings on social media by their online social ties. So for example, one person mentioned that they had a Facebook friend, or they followed someone on Twitter or Tumblr, etc., who would post things that were related to sexual health or HIV/AIDS. And also they encountered advertisements while browsing the internet. Something else that was pretty common is quite often the online social network of participants, consisted of other young Black MSM and other, gay and bisexual men of color or media personalities that were forward facing, and seen as, popular members of their communities. So as I mentioned, the internet was a primary source of HIV information, but we wanted to, get a better understanding of why this was. And so quite often, the convenience of being able to use your mobile phone, to seek HIV information, and the ease of accessibility to do so was talked about by all participants, and the ability to get the information fast and from multiple sources. But people also use the internet to seek HIV information because they had diminished access to their most preferred and most trusted source of HIV information, which were medical doctors and healthcare providers. And so when I probe to get a bit deeper into why they didn't have access, a few things came out. So a lot of people sought HIV information, online, in private as a way to mitigate against anticipated and experienced intersectional stigma. And so if you're not familiar with what intersectional stigma is, that refers to stigma, like the intersecting stigmas that the young Black MSM encountered due in part because they have multiple intersecting socially constructed identities that make them vulnerable for mistreatment by and within societal institutions and in their communities. And so intersectional stigma in this case refers to stigma that's rooted in racism, homophobia, or HIV stigma. And as I mentioned before, my study was comprised of men who are living with HIV and men who are not living with HIV. And so for participants who were living with HIV, they dealt with, HIV stigma. And for participants who were not living with HIV, they dealt with presumed HIV status. And so a lot of participants talked about, even though they weren't living with HIV, they were presumed to be HIV positive because they were Black and gay. And so, some of those anticipated or past negative experiences, dealing with intersectional stigma in healthcare settings put a lot of people off from communicating with healthcare providers, and so they avoided, interacting with healthcare providers as much as possible. And so even if they had an information need that they thought could be met by a doctor or healthcare provider, they still just looked for it online. And then also another reason why people engaged in internet HIV information seeking was due to discomfort with communicating with healthcare providers about same-sex sexual behaviors. And so just to preface this, all the names below are pseudonyms. So all participants were given pseudonyms. So this isn't my participant's name, but he says, "I didn't tell my doctor that I was sleeping with men and he didn't ask. I'm already Black, and when they see me, they already treat me like I'm a statistic. I'd rather not talk to them about this stuff because I don't want them to treat me even worse." So I think that was a very, very illuminating, excerpt from that interview that helps maybe demonstrate what I mean when I'm talking about intersectional stigma and how, Black MSM cope with that. Something else that was really common in the study was that most people perceived the HIV information they acquired online to be accurate. And quite often when they determined accuracy, they were evaluating the authority and the trust of the source. So one participant here says, mostly because they give me the correct answer. It's really easy to navigate, and you can find reputable sources like .orgs or .gov that's really accurate, something you can believe in as a source. That's why I trust it. And then you don't have to go anywhere. Like you can pull out your phone and with a quick searching, know the answer in like 10 seconds. But for other participants, there were still concerns about privacy, even when using mobile devices to seek this kind of information. And so several participants talked about using private browsing mode when searching for information on their phone. And so Nathan here says, I usually use my phone and I like go into private browsing. Like you just start typing something, or if someone is using my phone, I don't want them to start typing something and then it all autofills and then I hear, hey, what's this? So there's still privacy concerns even when using mobile phones to search for information as a protective mechanism. And so, the various ways that HIV/AIDS information was used in this study was to manage and assess the risk for acquiring or transmitting HIV. And so you'll see here the participant is talking about, learning about medication resistance, and that being something to help him with, managing adherence to his HIV medications. And another way that information was used was to inform patient-doctor communication. And there were three ways that patient-doctor communication information was used to inform patient-doctor communication. The first being to self-diagnose. So many participants self-diagnosed themselves prior to seeing a healthcare provider. The second was by, verifying information, verifying the HIV/AIDS information they acquired online by speaking with the healthcare provider to see like, hey, is this true? Let me discuss what I saw on Twitter. And then the third being, seeking information to educate their healthcare providers about HIV prevention and treatment. So here, here are some illustrative quotes, but I want to go back to, information use to inform patient-doctor communication related to educating healthcare providers. And so here, this participant, John, he says, I just know I have a few friends that had experiences going to doctors, asking for PrEP or anything like that, and the doctor was very closed-minded or not very up-to-date on medical history and our aspects. We have to look for stuff on our own to tell them about it, and I don't like it. And so here, there's a gap in knowledge that the providers have about some of these new biomedical advancements, and the participants were saying they felt like the onus of this responsibility was on them, because if they didn't advocate on behalf of themselves or educate providers, they wouldn't get access to the information or the resources that they needed. Information was also used to support skills building for HIV prevention. And so here the participant describes, learning how to disclose, learning skills for how to disclose that he contracted an STI and how to talk to partners about that. And then also to understand HIV prevention and treatment options. So here a participant talks about learning, learning about HIV and learning about PrEP, and getting a better understanding of what those things were, for his knowledge development. One of the other major themes from this research was, the use of social media for HIV information support exchange. And so many participants discussed, highly valuing information that they found on social media from other, Black MSM or other MSM of color, for people talking about their experiences, either living with HIV or their experience using, prevention methods such as pre-exposure prophylaxis, or being in a mixed status relationship, which is, also referred to as being serial discordant. And then another concern that a lot of people had were, a lot of people mentioned diminished access to, these online communities, these online spaces for online social support exchange due to censorship policies on social media sites. So several people mentioned, when policies were enacted at some of the major social media site, social media site corporations, they lost access to some of their favorite accounts because they were banned or blocked, or certain things were no longer showing up in the algorithm. And so that really impacted these online spaces to get information that they deemed relevant to them. And there were also concerns about some of the information that they incidentally acquired online. And many people perceived the framing and tone of the HIV prevention information and messaging that they encountered via, mass media HIV prevention campaigns and advertisements as being, judgmental or pushy and fear-mongering. And so they felt that the message was very negative. And also one of the other major themes was participants were experiencing information overload, and they felt like they were being inundated with HIV/AIDS information in the form of ads when using social media sites and geospatial dating applications. And so these spaces that they wanted to use to find partners or for community building, it would overrun with ads, and so they were not a fan. And so I mentioned, two of the questions that were added to the interview guide based on input from my youth advisory board were about the information needs. And so these were some of the existing information needs that were identified by participants in the study. People wanted more resources about HIV and mental health. So if you're recently diagnosed, how to manage how you're feeling mentally about that. People wanted more information about navigating still discordant relationships and dating. Folks wanted to know how close are we, to a cure? How advanced are some of these biomedical advancements? Is a cure possible during their lifetime? People wanted to know more information about medication side effects. Help with navigating health insurance. And vouchers for various, HIV prevention drugs. People also wanted more information and more information that was specifically tailored to young adults and teenagers, because everyone in the study mentioned that they hadn't received any formal sexual education that was specific to gay and bisexual youth, and they wanted that. And then people also wanted more information about non-biomedical HIV prevention strategies. So if someone doesn't want to, doesn't want to take something like pre-exposure prophylaxis, they wanted to know what their other options were. And then people also wanted help with combating misinformation on social media. Many participants discussed seeing negative attitudes or negative attitudes and negative things that were being said related to HIV online, and it kind of reflected just a lot of ignorance. And so they wanted to know, what can I do to deal with this? And so one of the other things that was central to the study that I mentioned before, we're thinking about what are the factors in young Black MSM's environment that might deter or motivate their engagement. And so at the structural level, intersectional stigma in healthcare settings was a major deterrent. As I mentioned before, either experienced or perceived or anticipated intersectional stigma. There was also one of the other structural barriers or deterrents to engagement were diminished access to HIV testing. Many participants mentioned there were no locations in their close geographic proximity that offered HIV testing, and also the perceived cost of traveling to an HIV testing location were deemed to be too high, and thus people didn't obtain HIV testing. And many participants, also at the social level had privacy and confidentiality concerns about the physical location and setup of HIV testing facilities. This was also rooted in intersectional stigma, because people deemed the location to be too public, and many feared that members of their social networks, such as family members and even other members of the gay community and church members, would see them accessing HIV testing services, and this could lead to physical harm. It can lead to a loss of housing, a loss of family and community support, and then being further stigmatized in gay community spaces. And then at the individual level, one of the other deterrents was having a low perceived risk of HIV, either because, like abstaining from sex and few acts of sexual intercourse, or, something else that was common. Some people, didn't access things like HIV testing because they were in a monogamous relationship and assumed that their romantic partner didn't have any additional, sexual partners either. And then finally, fear of receiving an HIV test result. People were afraid of what their life might be like. If they found out they had HIV. They feared, once again, like social isolation. And people also were concerned about the long-term costs of medications and managing health living with HIV. As far as the motivators, at the structural level, free or low cost, HIV testing services, convenient testing location, and recommendations from a healthcare provider. At the social level, one of the major motivators was social support, which includes, which in this study included informational instrumental and appraisal support. And so instrumental support included, getting tested with a romantic partner or with friends, or being even transported to an HIV testing location by a friend or romantic partner. And appraisal support involved, the encouragement to get tested for HIV. So particularly by other Black MSM, that was really important. And at the individual level, health maintenance was one of the primary motivators of being engaged in HIV prevention and care. So, you're wanting to just minimize, your own concerns about your health, or it was part of your routine health care, but also people who may have been experiencing what might be described as flu-like symptoms. And so it was like, oh, let me go see what's going on and go talk to my healthcare provider. And then for other folks, the fear of not knowing your HIV status was a primary motivator. It's like, I don't want to not be in the know, so I'm gonna be proactive about my health. So what does all this mean? What are the design implications of this study, and for the development, the further development of this informatics intervention? So here are some of the key considerations that I have so far. I think it's absolutely critical to develop HIV informatics interventions that are designed to combat intersectional stigma. So that includes developing stigma reduction interventions. It's important to also consider things like access, privacy, and confidentiality. Those are key design requirements for an intervention. And then also shared decision support, making sure that there are maybe clinical decision support tools that help healthcare providers readily become more aware of HIV prevention and treatment strategies, and so that the onus of that education does not fall on young Black MSM. The responsibility should lie at healthcare providers, but then they also should make these decisions together. So getting a better understanding of what are all the options that are out there, and figuring out which prevention and care options are best for the individual. And then also addressing some of these information gaps that I mentioned in one of the previous slides, having interventions that provide the type of information and resources that participants want to see. And finally, community. Community is very important. So as I mentioned, a lot of the participants discuss lack of access to or diminishing access to, online community spaces. And so we need interventions that incorporate, participants being able to build their communities together online. And then it's also really important to use community informed language, because a lot of participants mentioned that the framing and tone of the HIV messaging they received was pretty negative. And so by getting feedback from participants about what that language might look like, such as being pleasure centric, or being focused on maybe sexual empowerment, that can help with improving how these campaigns are developed. And then also including serum discordant couples. Quite often when you see an intervention or a consumer health technology that's developed, quite often is focused on one particular group. So either people living with HIV or people not living with HIV. And something that was common in this sample was that serodiscordant dating was popular, and that the community needs to be together. So designing interventions that include people living with HIV, people not living with HIV, and people who may not be aware of their status is also very important. And then expanding the type of community partners that are often involved in HIV prevention and treatment research. So utilizing libraries, those were found to be a highly trusted source of HIV-related information. Collaborating with healthcare organizations that are led by Black and other people of color LGBTQ organizations is also really, really important. And so finally, keeping in mind, health justice. What is health justice? Health justice is more than equality in health. It is about lessening the existing gaps and who has access to health. When we achieve health justice, people in our community will have the economic, social, and political power and resources to make decisions about their bodies and health, regardless of identities and experiences. And that's the definition from the San Francisco AIDS foundation. So that means not only dealing with, some of these environmental factors that are at the individual and community level, but also addressing some of the structural barriers to everyone, having what they need to live well with HIV or to prevent HIV. So I'd like to thank you all for joining me today. Here's my contact information if you'd like to chat after, and also my Twitter handle. Thank you all for listening, and now open the floor for questions.
Great. Thank you so much, Dr. Threats. This was wonderful to have you speak, and the first speaker as part of our special seminar series. We're thrilled. So are there any questions from the audience?
I think I see one hand raised, Sal.
Oh, great. I can't see everyone, so great.
Sorry, in the car, so my
Oh, it's okay.
Dr. Threats, first I just wanted to say thank you for an amazing talk. I wanted to ask about how trans feminine or maybe trans women populations factor into the research around this, or how they factor into statistics, and if not, already grouped in, if categorization had been done on biological sex or sex assigned at birth, how that would be affecting the development of informatics resources, designed in future interviews.
That's an excellent question. So something that I'm grappling with myself is trying to make sure that we're not like reproducing like inequities, right? And so quite often, sometimes something that happens in public health research is that trans feminine communities or trans women are included in research with men who have sex with men. And just in some of the research spaces I've been in, when I've had conversations with trans women, that in itself is stigmatizing. They don't want to be rolled in with men. They want to be in interventions that are designed for women. And so something that I'm doing in my future work right now, I have a study open for recruitment that looks at sexual and reproductive health resources and information among trans women and cisgender women of color, and focusing on their needs. And so I try to be very intentional about, if I'm doing a study for men, that includes, men who were, trans men and cisgender men as well. And then when thinking about, trans feminine communities, cisgender and trans women are together as well. So for this work, it's only focused on, cisgender men and transgender men.
Wonderful, thank you for that. I'm glad to hear that also you're doing work towards that as well.
Yeah.
Great. Other questions? And please speak up if I can't, see that you've raised your hand.
Yep. Hi, Dr. Threats. Thank you so much for a wonderful presentation. I'm wondering about meeting some of these information needs, and what might the best way for delivering some of these interventions might be, and if like a gamified approach might meet some of the needs for this population.
Thank you so much for that question, because that's something I didn't get to like the next step. So in this study, no surprise, technology use is very high, and folks had a lot of experience with using different types of technologies. So whether that be like tablet technology, smartphones, but like 75% of participants own gaming devices. So I said, since everyone likes to play video games and everyone owns a gaming device, maybe that might be a way to deliver some of this information. So I actually, in the process of developing, actually using a gamified approach, and I actually worked with folks at the Columbia Social Intervention Group. We had a hackathon where we developed a vertical slice of a video game based on this research. And so that's in the early stages of development, because that might be a strategy that hasn't been used quite often. There's a few folks who have labs like the Games for Play Lab and the Behavior and Technology Lab who are doing works like doing gamified approaches or developing video games. And so that's actually going to be the next stage of this process, is the development of a video game, beyond just the vertical slice, like making the actual playable prototype, to deliver some of this information through an intervention to see, does it improve linkage and retention in HIV prevention and care, and are these information needs being met? That was a wonderful question. Thank you so much.
Awesome. That sounds, I look forward to seeing that. My other question was about family and the stigma with family, and if there's ways for interventions to help facilitate skill building around communication, self-advocacy, things like that.
Yeah, definitely. So something that came through in this study was that the institution that had the biggest influence on their families were churches and faith-based organizations. And a lot of people had like this, I don't want to call it a weird relationship. It was like, the churches shared negative messages related to, same-sex sexual behavior and homosexuality. But despite these negative messages, they were still very much connected within these institutions. And they still very much valued these spaces as a spaces for, cultural expression and just community and closeness. And so they weren't going to leave these organizations. And there's research that shows that sometimes, religion is something that isn't considered enough when looking at this particular population in comparison to their counterparts of other ethnicities, but it's still very much a very important institution within their lives. And so as far as, addressing some of the family level stigma that happens there, I think there's a really rich opportunity to do collaborations with faith-based organizations and put the onus on the institution instead of the individual. Have a faith-based organization learn more about HIV stigma, become more aware of how to not perpetuate those messages. And in that, it's kind of like this modeling, like, if the church says this is what goes, and this, this filters down to like our communities, and hopefully that will help shift some of the attitudes. So I think that was a really great question, and I'm hoping like more faith-based collaborations in working on reform there can help with how participants are treated within what I might consider like Black cis heteronormative communities.
Fabulous. Thank you so much.
Thank you, Adrienne.
Great. Other questions? Well, I'm curious. I wonder, and it seems like so many topics we think, well, how did this year influence them? But I wonder if you've either thought about that, or there is some data about perhaps different information seeking patterns or care seeking patterns that have occurred over the past year, with certainly all the impacts to our daily lives.
Yeah, so there's been some research on like information behaviors and practices among different groups, but not so much among young Black MSM. And something else that I would be interested in learning more about is like how these behaviors shift over time, like due to like various like life events, maybe like even considering like the COVID-19 pandemic. And maybe you're not accessing the care you want because you're not able to go in person, and you're relegated to like telehealth appointments, which you may not be comfortable with, because then you're at home and you're around your family. And so it's like, well, I can't have a telehealth appointment, right? Like I can't look for this information there. And so then what does that mean for your healthcare outcomes, right? Like, even if you need this care, you're not able to do it. You're not able to really fully get what you need. So I think that's a great question, and I would be interested to maybe do more exploration on that in the future.
Yeah, great point about the potential lack of privacy with telehealth visits, depending on your living situation.
Thank you so much for the question.
Any other questions? No, well, this has been a wonderful discussion, and thank you so much for presenting to us. We're thrilled to have you. And so a virtual round of applause, which we'll have. Again, thank you so much
Thank you.
for joining us.
Awesome.
Okay.
You all have a great weekend. Thank you so much.
You too. Okay, bye-bye, everyone.
Bye.